Inshallah. Okay. Okay. Continue, isn't it? Okay. Good afternoon, everybody.
Next slide, Prof. Enter.
Let me remove this. Okay. Okay. Good morning, everybody. Good morning. Good afternoon. And Assalamu alaikum wa rahmatullahi wa barakatuh. And today is our topic is a topic that has been very common in our community. But nowadays it's getting less and less. I remember when I was in my beginning of my career at KCASH, we are seeing these cases or lens-induced glaucoma probably on weekly basis, more than a case or so, especially Phacomorphic glaucoma. Nowadays, you probably, as you noticed, that these forms of glaucoma is getting less and less, and this is related to the improvement in many aspects, healthcare and patient awareness and many things. So, but still, unfortunately, doesn't come away. But still, unfortunately, can I get this one? Some of these still common in certain developing countries, especially the Phacomorphic glaucoma here and lens protein glaucoma, or at a lesser extent, lens protein glaucoma, and Phacomorphic glaucoma is common still in many developing countries. So lens can induce glaucoma in many ways, and through different mechanisms. If we need to make it easier and also to have an effective therapeutic approach in their management, we need to divide them in categories according to what part of the lens and through what mechanism the lens induced the glaucoma. For example, we can say, or there are actually three categories. We have three categories, either due to the lens size. Where is my picture? So I can see my picture. So I can see it.
Which one? This one?
Okay, so yeah, so either due to the lens size, in which the size of the lens, such a lens, gets swollen and became disproportionate to the size of the globe, causing elevation of the pressure through mechanisms that will go over in a few minutes. Then, or the other category, due to the size of the lens, whether a normal lens or abnormal lens. So this lens has or became partially mobile. This is subluxated lens. It is a subluxated lens, and this movement or uncontrolled movement of the lens can induce glaucoma again in a different mechanism. Similarly, totally dislocated lens. This lens in the anterior chamber has a completely freely mobile, and now either causing a vivarially block, or even touching the endothelium. In this case, is not touching the endothelium, but the endothelium is at high risk to be touched by the lens. So such a case, we need urgent intervention. Then the third part of categories. So we talked about the size. Now we are talking about on the site, and now we are talking about lens or lens material that is the cause of the glaucoma. So in this case, for example, this patient has a corneal laceration and also has anterior capsule laceration. You see the chamber is deep, so swollen lens, but didn't cause vivarial block or directly tamponade the angle. No, the chamber is very deep, but The pressure elevation. The pressure elevation is due to escape chunks of the lens matter clocking the angle, causing what is called lens protein glaucoma. So lens particle glaucoma in this case. So of course, the lens material can cause glaucoma in more than one way. This is one of them, lens particle glaucoma, as we'll see later on. So the condition will take them in a little bit more detail, and we'll see the mechanism and so on. So condition related to the size of the lens, as you see here, this swollen lens, very swollen lens, definitely, as you see no chamber probably, or extremely shallow in the center, but it is a iridocorneal touch almost, and the lens is swollen. This will cause glaucoma either when this is almost most commonly in the intermittent cataract or traumatic cataract. So the mechanism of elevation of the pressure is due to pupillary block, as you see here, or due to and probably direct angular closure. The lens itself can lead to a pupillary block. In the same time, the lens is large enough to even tamponade the iris against the angle in this area, or even both mechanisms can work together in some cases. So this is the Phacomorphic glaucoma that we are calling it Phacomorphic glaucoma related to the size of the lens. So this is a type of lens-induced secondary angle closure glaucomas, one of them. So what is it? It is, yeah, here again, it's a swollen lens. The swollen lens lead to pupillary block. Pupillary block will lead to iris bombay. Iris bombay will lead to angle closure. But again, as we said, the swollen lens, which became a disproportion to the size of the globe, can lead to direct angle closure. Most of the time, both mechanisms working together. So as you see here, the lens is swollen, so it can directly push the iris against the angle with or without a pupillary block. Good. So the stages of the Phacomorphic glaucoma, either first pupillary block, then angle crowding, then chronic angle closure, and this form is more common. You see, yeah, more common in smaller eyes, hyperopic eyes, but also can occur in other forms of, or in metropic eye, even in myopic eye can occur, but it is rare, but can occur in a metropic eye. And the other thing, it is more in common in developing countries, and we know what's the reason why it's still encountered in developing countries, because many aspects, whether, you know, the lack of health services, patient education, poverty, many things that can make this form of glaucoma common in these countries. And predisposed by rapidly developing intermittent cataract, especially in diabetics and so on. They develop very quickly, or traumatic cataract. The clinical picture, this is one, you can say it, one of the acute congestive glaucoma. They present to the emergency room, almost always to the emergency room, or even, So as an acute congestive glaucoma, similar to many types of congestive glaucoma, on top of them is acute primary angular closure glaucoma, lens protein glaucoma, uveitic glaucoma, neovascular glaucoma, many of these acute congestive glaucoma. So when you see the patient, you will see that the patient have a high IOP. He is in pain also due to the high IOP, corneal edema, again, due to highly elevated intraocular pressure, and mid-dilated, you will find the pupil is mid-dilated and fixed non-reactive, as well as shallow anterior chamber, as you see here, very shallow anterior chamber, and closed angle if you're able to do gonioscopy, although patient will not let you to do gonioscopy. He's in agony, he's in pain. So, but when you do gonioscopy, the other eye will will see that this patient is, to begin from the beginning, most of them at the risk of developing this type of glaucoma. And when you check the vision, you will have you will hear from him that his vision is deteriorating over the last weeks or months or years, and sometimes it's only faulty light projection. So diagnosis is mainly on the clinical picture. It's not that difficult to diagnose phacomorphic glaucoma, but again, gonioscopy is very important. Gonioscopy of the same eye if possible, but sometimes, as I said, it's difficult to do gonioscopy. This swollen lens, even dentation will not help you much. So, but the gonioscopy of the other eye will give you a lot of information that can help you reaching the diagnosis. Ultrasonography is essential before you take the patient to the OR. Even sometimes UBM is important to rule out any cerebral problem, posterior segment problem, especially the mass lesion and so on. So it is very important to do that. And the management, it's medical management, medical treatment to lower the intraocular pressure in acute phase, including hyperosmotic agents. And these eyes are inflamed, so they need frequent topical steroids. They need frequent topical steroid to quieten the eye and to prepare the eye for the next step of your management. As we'll see, again, pilocarpine is important. Some will say that the iris sphincter is ischemic and will not react. Some of them, patient, because of the ischemia or pressure is high, when you get the pressure is low, you may get a little bit of changes in this bevel size, or even at least if there is still fibers will prevent, when you hit the iris, prevent the iris from movement, hopefully. And then, of course, laser iridotomy is a mandatory. And then at this stage, you need to stop, delay more intervention, quieten the eye with the steroids, after laser BI also, titrate your medication, and see how the IOB or the intraocular behaves. You can examine him and say the next day or the day after or in a few days and titrate the medication and see, even if you can do gonioscopy on this eye, looking for the history or the duration of the problem. So you can then tailor your intervention. Do you need to go for cataract extraction only, or we need to join it with or combine it with trabeculectomy? So it depends on the status of the angle, status of the other eye, status of the pressure. So sometimes if you examine the other eye and you find the other eye's angular closure, so that means this eye also an angular closure and aggravated by this intumescent cataract. So probably, and the pressures didn't respond to the medical treatment and laser or little response. So you need to combine it with trabeculectomy. So yes. Oh, okay. All one, that's fine. Yeah. Anyhow, so at the same time, don't forget the other eye. The other eye, you need to look to the other eye to see if it needs laser, and most of the time they need apoplectic laser treatment. So yeah, what are the advantages of laser PI? It relieves the acute attack. Acute attack of if we succeeded to do it, allows more time for the eye to quiet preoperatively and to take your time to allow evaluation of the angle. We need what type of surgery we're gonna do for this patient, and also allows safer pre-op mydriasis and risk of the iridotomy, bleeding, of course, inflamed eye, endothelial injury, rupture of the lens, which is not a big deal, or failure of the BI of the iridotomy. You couldn't perforate the iris, so what you will get is just more inflammation. So this you can quieten it with steroid. Then Yeah, there are intraoperative difficulties in this type of glaucoma, secondary glaucoma or secondary angle closure glaucoma, difficult capsulotomy because of the view, let us see, fixed mediated pupil, uh, uh, fixed shallow and anterior chamber with posterior vitreous pressure, poor view, cornea edema, descent detachment, sometimes weak zenioles. So you need to be very careful, and you need certain hints to avoid or to manage these skins. Poor view, this problem. Poor view. You can do a preoperative mannitol, give it preoperative mannitol, topical preoperative glycerine, even scraping of the epithelium, and fixed midday pupil. You can mechanically do mechanical mydriasis by viscoelastic material, pupil dilator, pupil dilator, retractors, small sphincterectomy sometimes, sector iridotomy if you want, and these are very important to have an optimized eye as much as possible to do the lens extraction. Deepening capsule, again, difficult capsulotomy because of the shallow AC, so deepening the viscoelastic material through the paracentesis, or even puncturing the lens at the center to aspirate some of the material, so you will get release of the intraocular contents, and you may have a better chamber. But most of the time, it's difficult to. So difficult capsulotomy due to the shallow AC and posterior vitreous pressure. What we are doing is limited bars planar vitrectomy, only cutter, and this is, we are privileged to do that. Sometimes you need to do it in which you go 4 millimeter from the limbus with an MVR plate, directing the MVR plate to the blindly to the optic nerve head, and make sure that they not go too much. You have to make, for example, 6 or 8 millimeters and put a clamp on it or so you will not go further. And then with the cutter only, no irrigation, it will be probably 3 or 4 cuts. This is enough. You will soften the eye, and then you will deep the chamber. You will have really a very good, or let us say, a suitable eye to complete your procedure. This is very simple and very effective. Triban blue, of course, for capsulotomy, whether you want to go circular capsulotomy, if you are planning to go for phaco, or if you want to go for ECCE, you can go can opener, or even for phaco. Well, it is not advisable, but if you are going to do ECCE, you go start the can opener at 12 o'clock in the superior 180 degrees, because the view will be disturbed by the liquefied material. You can inject healer and so on, and it's sometimes difficult to complete the can opener in such situations. So make sure that superior part is already cut. So when you deliver the nucleus, there is nothing in front of the nucleus to prevent it in strands of the capsule or whatever. So this is very important. Then intraoperative because desert detachment, you have to avoid repeated going in and out of the eye. So these are very important. These difficulties, I think, yeah, there are, probably you'll find something in the YouTube or so, or even our people here, we can do these things in front of them sometimes if we need to do so. So then the condition related to the site of the lens, that one, site of the lens. Again, site of the lens, as we said before, such a lens, it is, a partially mobile, subluxated, or dislocated total anterior chamber. This lens will lead to either biliary block, or even biliary block with even affecting the corneal endothelium. So in this case, if it is in the posterior chamber, this will lead to direct tamponading of the angle by the iris in different positions depending on the patient position. So in its management, or the mechanism is direct angle closure, and it might lead to biliary block. So in managing these cases, although they are not so common as the other common forms, the Phacomorphic and lensoproteinic glaucoma. So the management of the subluxated lens here, as long as the posterior chamber, you can put pilocarpine and do iridotomy 180 degrees apart. but as long as it's a clear lens. And here you need to intervene urgently if it is anterior chamber, whether from posterior approach or anterior approach or posterior approach. It depends. If you're going to go anterior approach, you need to put pilocarpine. So to constrict people, the lens will not sink back to the vitreous, and you can remove it from anterior approach. But the definitive treatment for these cases is first of all, all of us, we need to be familiar with the long list of ectopia lentis like trauma, Marfan syndrome, high myopia, pseudoexfoliation, mature cataract, and etc. There are many syndromes and many conditions that are associated with ectopia lentis. So the treatment, as I said, the definitive treatment is lens extraction, whether anterior approach or posterior approach. This is very important. Then we come to the other important I'm looking to the my mobile. Sometimes some of the attendee, they send me a message that it's a problem, but anyhow. So the third category is the conditions that related to the lens material itself. This can be either lens protein for glaucoma, lens protein glaucoma, or what is called in the past phacolytic glaucoma. This is described by Fawkes in 1955, and the mechanism of this disease is heavy molecular weight lens proteins. Many authorities questioning the role of macrophagic response in this disease. So a clinical picture, as we said, usually you find an eye harboring mature or hypermature cataract, heavy flare, even sometimes pseudohypopium from the soluble lens protein that has came across the holes in the anterior capsule. Then white patches on the capsule. These white patches represent macrophagic response to trying to seal this holes in the capsule, and then open always deep chamber and open angle. Again, the patient present again with as an acute congestive glaucoma, severe pain, as you see in this patient, and she had with due to high IOP, and this patient had cautery around the eye to relieve the pain. This is one of the traditional treatment, and usually they have very poor vision, light projection or light perception with faulty projection or so. And the IOP is usually 60, 70, and hyperemic conjunctiva or conjunctival injection. Corneal edema is common, and pseudohypopion, as I mentioned earlier. This is if the leak is very marked leak, you can form a pseudohypopion. So, and usually ridotomy. The patient, especially in our community, but not nowadays, of course, as long as they are managing, they don't seek medical advice. So the patient, the other eye is either aphakic or pseudophakic, doing well, and neglect his other eye until he comes with this type of glaucoma. So what is if we go to physiology, to understand what's going on, lens protein, represent about 33% of the total weight of the lens. 85% are soluble proteins, and which is consist of alpha crystalline, 15%, 55% beta crystalline, and gamma crystalline, 15% also. And the remaining 15% is insoluble. It's insoluble albuminoid. So what happens with cataract formation? Heavy molecular weight lens protein forms. What does mean that? That means with cataract formation and aging, the lens molecules of protein, or the protein molecules, aggregate together and forming a giant molecule. This increases with age and cataract formation, mainly in the nuclear region, and absent infantile and juvenile glaucoma. And when we look to these experimental studies, they found that perfusion of nucleated human eyes with 0.5 milligram of this heavy molecular weight lens proteins lead to severe obstruction of the outflow facility. And if you increase perfusion time, lead to more obstruction. And you know, if you irrigate the eye, trying to wash these material from the anterior chamber, irrigation with BSS, or even alpha chymotrypsin enzyme, which is used in the decades before to dissolve these nodules in the era of intracapsular cataract extraction, again, doesn't affect or relieve the obstruction. So this heavy molecular weight lens protein stay in the angle, and take this in your mind later on. We'll see how we can get rid of it. And if you perfuse this eye with low molecular weight lens proteins, there was no obstruction. For 1 hour, there was no obstruction, indicating that this is due to the heavy molecular weight lens proteins. A clinical studies also, patient with lens protein glaucoma, that when they found that this heavy molecular weight lens protein represents 35% of total protein. يعني protein احنا we said before انه represent about 35, and 35 of it is heavy molecular weight lens protein. That's mean about 0.8 milligram. So, and we mentioned that 0.5 milligram can lead to severe obstruction. So here, 0.8 milligram is well in excess to cause this obstruction. And they found that no heavy molecular weight lens proteins in normal subjects with immature and mature cataract, those who have it, doesn't have this disease. And again, when the phacolytic or lens protein glaucoma hasn't been diagnosed in children after needling for their congenital cataract, despite of the presence of engorged macrophages in the anterior chamber. So this is again support to what we are gonna conclude from this slides or this topic. Again, David Yucker, our colleague, he injected silicone oil in the peritoneal cavity of a rabbit, and he got swollen rabbit macrophages and inject them in the anterior chamber of the rabbit, and they failed to elevate the intraocular pressure. Again, this is very important. So the authorities or the investigator, what they want to reach, they want to say that this mechanism of glaucoma and lens protein disease or lens protein glaucoma is simply due to obstruction of the trabecular meshwork by heavyweight molecular lens proteins. That this is their molecular weight. And what is the role of the macrophages, which has been in the Flock in 55, they said this disease is due to engorged macrophagic response, as you see here, this is from his book. And this swollen macrophages are the primary structure of the trabecular meshwork. So that with these studies, they said that simply due to this heavy molecular weight lens protein. So what is the role of this is here, what is the role of macrophages? Are they obstructors? No. Definitely now we can believe that it is not, but may add overwhelming the angle which is already altered by this heavy molecular weight lens proteins. So what is their function? Their function is relievers or scavengers, khadam, normal scavenger response, relievers. They are taking this material from the trabecular meshwork. So, and this is why this type of disease, when we treat them, we cannot remove the material that already in the angle, but the pressure normalizes, the eye normalizes itself later on because of this effect or this action of macrophages. They are taking care of this material inside the trabecular meshwork. So medical therapy is the management of this disease, additional anti-glaucomic therapy, hyperosmotic agent, topical steroids. These have little effect in controlling the pressure. But you need them to quieten the eye or try to quieten the eye and to prepare the eye for the definite treatment, which is removal of the lens. In the past, they recommend to remove it as an intracap to avoid that it may rupture the lens and take the nucleus to the vitreous and complicate the case. But nowadays, with improvement of surgical skills and surgical equipment and so on, ECCE, or nowadays, even some of the surgeons, they do a phaco, but I prefer ECCE in this situation with proper and sufficient INA or irrigation aspiration to take care of the circulating lens proteins in the anterior chamber, and then those remaining in the angle, the macrophagic response will take care of them. This is our patient. I remember this lady when in my career. This faulty light projection, you see the Morgagni cataract. Leukopai, this is an old scar, by the way, which is the same here. This was light projection or whatever, light perception or whatever. And now, after surgery, with normal pressure, her vision is 20/25 with healthy disc. So don't give up. You say, okay, this is a hand. By the way, in the past, decades or centuries, patients with Phacomorphic glaucoma and lens protein glaucoma, at that time they call it Phacoanaphylactic glaucoma, with poor projection, they neglect these eyes. These eyes are very functioning. And again, I will ask a question now. When you see such a thing, or phacomorphic glaucoma, you cannot see anything, how can you tell that this patient will benefit of intervention, surgical intervention? And I have stressed this point many times by simple questions, by simple tests. I will not say it now. So even you can learn how much is the affection of the optic nerve in this disease, as long as this can show the normal or no problem in the retina. So not the time now. So again, the other form of lens or glaucoma due to the lens matter is what is called lens particle glaucoma. This usually follows the bland or unbland extracapsular extraction, or even penetrating lens injury, as we saw earlier in this topic, or which is the most common procedure done probably among laser procedures, one of the common procedure, which is laser YAG laser capsulotomy. These can lead to lens particle glaucoma. So mechanism of lens particle glaucoma, this is the picture that I showed you earlier. It's obstruction of the trabecular meshwork by junks of free lens material. Inflammatory response, questionable. Is it has a role? I don't think. So lens particle glaucoma, as you see in this patient with poor extracapsular extraction, you see later on that there is a chunks of lens material, will lead mechanical blockage of the trabecular meshwork by the lens particles, retained lens matter. So the treatment, I think here, medical treatment is anti-glaucoma therapy, topical steroids, surgical. Every treatment is anterior chamber washout. Nothing needed more than that. Then we'll come to this, one of my patients also, long time, a Yemeni girl, for 15 years or so, and done cataract for her in her country. And then she came with this thick capsule. So laser, YAG laser, posterior capsulotomy and IOP elevation is a common. This is one of the common complications of YAG laser capsulotomy. It is greater, these complications greater or has a great risk in a glaucomatous patient, patients without IOL, and if you use more energy. So this patient, don't think that I did it in one sitting. This will be catastrophic. You will have a lot of lens material, you will have a lot of energy, and you will go or you will harm the patient. So you need to do it on multiple sessions. Okay, so this is very important. So, and then again, and more precautions to take, especially in glaucoma patient, but it is recommended in after each capsulotomy. You need to measure IOP 1 hour post laser capsulotomy. I know most of us is not doing that, especially if you didn't use a lot of energy and the capsule wasn't that thick. But in glaucomatous patient, it's a must. And prophylactic anti-glaucoma therapy, you can give prophylactic anti-glaucoma therapy, topical steroids for a few days, and And then it happened that there was a lens protein glaucoma related to the YAG laser capsulotomy. You need to give anti-glaucoma therapy, avoid myotics, this is inflamed eye also, and hyperosmotic agent, steroid, surgical, anterior chamber washout, even has been reported filtering procedure. To be honest with you, over in my career, I haven't or even heard from my colleague that they needed anterior chamber washout or filtering the procedure after YAG capsulotomy. Anyhow, but there's no problem if you feel that, for example, advanced damage of the disc due to a patient with glaucoma and the pressure is high after capsulotomy, and he's not responding well to the medical treatment. I don't see any harm to go and do anterior chamber washout or even filtering the procedure. The last thing is phacoanaphylactic glaucoma. Phacoanaphylactic glaucoma. This is, there is a lot of controversy on this issue, very rare, and even many authorities, they questioning the diagnosis or correct diagnosis of this disease in a living eye. They say that you need to have two things. But again, it's shaded with it a zonal inflammation with a lot of KBs, and the incidence of this due to the patient genetic makeup to lens proteins. They said to correct or to diagnose it correctly, you have the polymorph nucleoleucocytes is the predominant inflammatory cells. And in addition to that, you have, when you check the lens matter in the anterior chamber or in the vitreous cavity, shouldn't be sufficient to elevate the intraocular pressure. So what they want to say that they said mainly polymorph nucleoleucocytes, they are the main inflammatory cells. And when you look to the amount of lens matter in the posterior chamber or in the anterior chamber or even in the vitreous, you don't feel that this is enough to cause elevation of the intraocular pressure. So, as I said, diagnose, to be honest with you, and I haven't diagnosed it. Maybe I misdiagnosed it, but I haven't seen it to be again. But people or the investigator and authorities, they questioning its diagnosis in a living eye. Then, so in summary, when we are confronted with a patient who has elevated IOP with opaque cataract, we need to approach this patient in a systematic way. We need to look, of course, after checking the pressure and checking the vision and so on, and the history and so on. We need to see with what type of glaucoma we are dealing with. Are we dealing with open angle or closed angle? If we are dealing with open angle, it should be either a pre-existing primary open angle glaucoma or real lens protein glaucoma. This is an intact capsule. But if you say that the capsule has been ruptured, I mean, or after trauma or after cataract, you may, again, open angle, you may include those who are lens particle glaucoma or even other types of glaucoma or a combination, lens protein glaucoma with lens particle glaucoma. If the angle is closed, then we need to look, is the chamber is deep? If it is deep, that probably we are dealing with the pre-existing angle closure glaucoma. First time the patient comes to us with high pressure and he has mature cataract or immature cataract or advanced cataract, probably has, this lens has nothing to do with the glaucoma, with the pressure. This patient has already pre-existing angle closure glaucoma. If he has a shallow chamber, then could be an accelerated primary angle closure glaucoma or a real true Phacomorphic glaucoma. If the chamber is very shallow, then probably an advanced Phacomorphic glaucoma or even an aqueous misdirection. We don't know. Could be an aqueous misdirection. He might have laser treatment or whatever, and he developed aqueous misdirection. At this point, probably I try to save some time for intervention or, sorry, for discussion, comment from colleagues, and I'll stop at this point. Thank you very much. Okay. Mona. Okay, any question, any comment from colleagues who want to add something that probably I missed? Yeah, show me the, show me. No, I will not touch these things. Okay, show me my picture and the pictures of intervention of these. Do you hear me? Hello? Well, nobody, probably I'm talking to myself.
الله يحفظك دكتور معك.
كويس اوكي. يعني ما كان في انقطاع في الليكتشر؟
لا ممتازة، من أحسن ما يكون. الله يبارك فيك.
الله يحفظك. Okay, questions, comment from colleagues. Okay, yes.
Yes.
Thank you very much. Thank you very much, Dr. Saleh.
من معي عفوا؟
دكتور علي البشري، كيف
هلا
حالك؟
علي دكتور علي، يا هلا والله مرحبا.
Thank you very much.
أهلا وسهلا.
Very comprehensive. Well done. Thank you very much.
Thank you.
Just one question related to the clear lens, lens-induced glaucoma. Like when we see a patient with 20/20 vision has a thick lens, which is already clear, but it affects the angle by pushing the iris against the angle. So I have a patient where I just removed the lens and he did very well after just removing the lens with just lens aspiration.
How old is the patient?
He is like 50.
Okay.
And the pressure was about 30 and above on medications. Just remove the lens, the patient feel comfortable and the pressure come down.
Yeah, agree with that. This is not, you are lucky because your patient is 50 and he lost most of his commutative power. So this can happen. I have two patients now in the 40s, and one eye has been done somewhere else and ended with aqueous misdirection. The other eye, as you say, the picture, very extended shallow chamber, clear lens, 20/20 vision, with, and the pressure is uncontrolled, disc still healthy. So I consulted my colleague from Retina, probably if Dr. Frashi Abdullah with us and Dr. Hakim with us. I consulted them. My plan was that one is controlled, the total coupling, of course, but it's still 20/20 vision, and that eye done somewhere else. And the pressure is 6, but on atropine. And the other eye is high pressure with a clear lens, healthy disc. My plan was, or my approach in that patient, to go for the good eye, to do trabeculectomy, even with skewering the flap, and lensectomy with probably multifocal. She's young. I consulted them. They advised me to take it stepwise. Why you don't do trabeculectomy? And then if something happened, we can go for core vitrectomy and lens aspiration and so on. Now the patient is scheduled for core vitrectomy, lensectomy in the old eye with aqueous misdirection, previous aqueous misdirection with total coupling, and then we'll go later for the other eye, the good eye, the same procedure. But I agree with you, but you are happy, you are lucky that your patient is 50. Nowadays, you know, the angle closure treatment, or the what you call the trend now in angle closure treatment. There is a nice article in the Lancet that the best treatment, probably they found that it is superior to the conventional treatment, lens removal, clear lens removal in angle closure glaucoma is superior to the traditional movement, traditional therapy, BI, medication, and so on. So I agree with you. Yeah, this is what you need. Thank you.
Thank you very much, Dr.
For sure. Next, please. Any question? Where are the residents? Jasser, Abdurrahman, medical education, I don't know. Come on. يا ما انكم فاتحين ده الاسامي وانتم مو معقول انه there's no questions. ها؟ Questions. Khaliza, Badriya, Al-Ghamdi, Suleiman, Mordi, Al-Anizi. No questions. Come on. Al-Rizgan. They have no. Alal, Muzeni, Alia, or da. Majida. Come on. Okay. What do you mean? What do you mean no questions? Any comment from colleagues? Yes.
Excuse me.
Yes.
Can I ask one question, please, Dr. Saleh?
Yes, sure, please.
السلام عليكم دكتور صالح.
السلام ورحمة الله.
شكرا جزيلا على المحاضرة الجيدة. بس for dislocated lens glaucoma, you tell that you are use pilocarpine first, or will use the cyclo to dilate it and to release the lens to go back?
Yeah, a very good question. Extremely good question. Yes, if you think, for example, spherophakia, macrospherophakia, sorry, and it is dislocated in the anterior chamber, and you want to get it in the back, posterior to the arm, to the vitreous cavity. Yeah, you can dilate the patient, put it in a supine position. Even you may do a tympanoid or pressure on the cornea to push it back, and then construct the pupil if you want. If you are not good, this is good. You answer this question. Then you are not a rush for removal of the lens as long as it is posterior to the iris. So yes, you can dilate, you can push it back and construct the pupil, do your peripheral iridotomies in 180 degrees from each other, and you can plan the lens removal in a week, in a month, in a years even, but don't let it go or leave it until it reach a mature cataract or have a mature cataract, then will enter in different types of lens-induced glaucoma. So you need, if you get it away from the anterior chamber, back in the eye, not, injuring anything in the eye or not causing any glaucoma, further glaucoma, then you don't worry about the lens as long the capsule is intact and clear lens until it reaches a late stage, but I don't recommend this. Once there is a good time to intervene, you can remove it. Yes, I agree with you.
Thank you very much, Dr. Saleh.
Sure.
Yeah.
Okay. Yes, any other question? Questions, please.
One of the approach, Prof. Saleh, and such phacomorphic glaucoma cases, where you have already edematous cornea and inflamed eye, it's better to go for stepwise surgical BI first and keep the eye on frequent steroids, and you can wait for a couple of weeks. Once you have the eye is already quiet enough, you can go for phaco or ACCE. What do you think?
Yeah, this is the most appropriate procedure or approach. You don't need to rush. I said that you need to go and give medical treatment, laser, wait, and until the eye quiet and reevaluate and see, say in 2 days, 3 days, a week, 2 weeks, as long as the pressure now is under control, titrate your medication and see, do you need to go for cataract extraction, whether phaco or ACCE, whether you want to combine it with filtering procedure or not. Definitely, this is the most way to optimize the eye to intervention, keeping in mind that the IOP is well controlled. You don't say, okay, well, with 2 weeks, your pressure is 50 or 40. Your treatment didn't help, your laser didn't fail or didn't help. You don't, and your frequent steroid, with the frequent steroid, you need to go earlier or shouldn't wait that long. Yeah. Any question?
Good afternoon, Dr. Saleh. I'm Dr.
Good afternoon, my dear. Yes. How are you?
I'm Dr. Konrad Shargel from King Khaled Eye Specialist Hospital.
Oh, more than welcome.
I really enjoy your lecture, and I'm totally agree with your comments and Dr. Ali Bashri's comments. And if you allow me, I would like to make a comment too.
Sure.
Regarding this kind of patients. Sometimes I'm totally agreed that the best option to do the surgery is when the eye it's cooled down after this intense episode. And sometimes we are able to see a patient with a cataract. And even if we know that the patient has a poor visual prognosis, but is a high risk patient for developing one of these phaco-induced glaucoma, I really believe that it's, if the eye is quiet, it's better to try to remove that cataract instead of waiting until the decompensation of the glaucoma. What do you think about this?
I agree. Agree with you totally. If you, as I understood what you're saying, you said that if you have a patient with poor visual potential, he has lens changes, and instead of waiting to develop a true lens-induced glaucoma, regardless whether phacomorphic or lens protein glaucoma, you need to go and remove the lens. I agree with that. Even if he has a glaucoma, this is, of course, it's a good indication to go and combine it with the glaucoma surgery, as far as I understood your question, your comment. I agree with you.
Yes, and this is one of the things I said to the glaucoma fellows everywhere. I really believe that the glaucoma specialist must be one of the best anterior segment surgeons, able to deal with all the most difficult cataract. So I'm doing just a small commercial for us. Thank you.
No, you know, my mentor, this is 30 years ago. Before even we start, or 35 years ago, I was resident, our fellow. His name is Karim Toma. He's a Lebanese, but he's one of the best people, or people that I will never forget them. He said the best cataract surgeon is a glaucoma surgeon. So thank you for, again, strengthening this belief. Thank you very much.
My pleasure. I really enjoy your lecture, and
Thank you very much.
willing to hear you again. Thank you.
Thank you, Doctor. Any other questions? So it is probably, if you have no questions, I'll give you this 9 minutes or so.
Saleh?
Yes.
Thank you for this nice lecture. I have small comments. Maybe this would be of value for some cases. If you have a shallow AC due to inflated lens in phacomorphic glaucoma or severe hyperopic eyes with very shallow AC, one of the nice tricks that I'm using recently for the last few years, I introduce 27 gauge needle in the vitreous, and I aspirate just 0.1 cc. It make the life is very easy for those with very shallow AC and very difficult approach, especially with the crowded anterior chamber. It's very easy. Just aspirate 0.1 cc with 27 gauge needle as you inject intravitreal injections like what we are teaching our resident. And really, I found it's make a big difference. Phacomorphic glaucoma, very shallow AC, nanophthalmic eyes, and many cases, and also in cases with aqueous misdirection that develop on table, and in cases with severe positive pressure that you want to give instead of giving mannitol and waiting for like half hour to work. So I found this technique or trick works very well.
I agree with you, but probably I'm not in favor of using a needle. You know, if you have a problem with our usually intraocular, shadow chamber, whether phacomorphic or even nanophthalmos or even a simple cataract extraction, sometimes, yes, there will be a vitreous pressure. And instead of going with a needle and aspirating vitreous, I would like to go with a cutter, only vitreous cutter, a vitrectomy, and few cuts. Or even blindly, you don't see it. If it is there is a view, that's perfect. If there is no view even, and you rule out any posterior segment problems, you can go with the cutter and few cuts. It will soften the eye. It will make your life easier. I agree with you, but for this simple vitrectomy or limited vitrectomy, but I wish to use a cutter rather than a needle. Okay.
Yeah, I agree with you, but the cutter sometimes is not practical, not easy for every person to use it. And if you want to go with the cutter, you need to create a sclerotomy or use a trocar.
No. Cutter the needle, same needle. I mean, 23 gauge needle or MVR blade with the cutter only, without a sleeve, and just a bit of push it, you know. But you need to
So
be
you
privileged
need,
for that.
yeah, and you need to open a new pack. But I'm talking about simple procedure that uses the needle, 27 gauge needle. Usually you will aspirate
Yeah,
0.1, you will aspirate only fluid, most of the time.
I know what you mean. Even you can say, well, now I'm in the OR and I know I don't have an acute home, then probably this is justified. But even if you are in a hospital and these things, you know, it is very dangerous aspirating vitreous by the needle. If you are in a hospital where there is acute home and you are not probably familiar with it, or you want the privilege to use bars plana cutter, you can ask your colleague, and it even happened with me. One of my colleagues in private, even, he said that there was a problem in forming the chamber, ECC alone, or cataract phaco alone. So he called me, and I came. I found that he has to do some to cut some of the vitreous by the cutter. So I was standing with him, and he did it. Yeah, very simple. It doesn't need and under my supervision. Doesn't need that much. But in case you have no people around, you have no cutter, or you are not familiar with the cutter, the acutome, I mean, you can do that. But my advice is nowadays in this, I mean, time, I don't like to go aspirate vitreous without cutting it. Yeah. Yes. Okay, good. That's very good.